Welcome to the August 8th meeting of the Board of Directors of the Washington Township Healthcare District. Good to see all of you. If you'd rise and will join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Dee, if you would take the roll for us, please.
Director Stewart.
Present.
Director Wallace. Director Epen.
Present.
Director Nicholson.
Present.
Director Danielson.
Thank you, Dee. We'll now have an education session. Nancy, if you could introduce that for us.
I'd be very happy to. Tonight, presenting is our very own Paul Kelly, who heads up our biomedical engineering department. He is our director of biomedical engineering and also the Green Initiative here at Washington Hospital. This year, he will celebrate his 20th year with this hospital. That makes him a youngster. He is very active in the biomedical engineering field and is on many committees, including the International Standards Committee, National and State Level Board of Directors, and the Joint Commission Patient Safety Advisory Group. He's spoken at conferences, authored many articles, and has even authored a textbook chapter. He's been recognized as the California Medical Instrumentation Association Professional of the Year for our state, the Association for the Advancement of Medical Instrumentation BMET of the Year for the United States. The American College of Clinical Engineering Professional Achievement in Management Managerial Excellence Award is also his. He's also been profiled in several magazines. He also serves on the AAMI Sustainability Standards Committee, where they are developing environmentally focused standards for medical equipment. He attended the first ever Hospital Sustainability Coordinator training in October of 2008. Under his leadership, Washington Hospital sustainability programs have been recognized and awarded many honors. He has always been interested in reducing waste and likes to reuse and repurpose things. He is a member of the City of Fremont's Environmental Sustainability Commission. He is active in many groups and hopes someday to attend the Climate Reality Project training by Al Gore. And with that, I'll turn the program over to Paul Kelly.
Hi. Good evening. Thank you for allowing me to brag about our environmental sustainability achievements. This slide was from our very first Green Team meeting, exactly 10 years ago today. The meeting on 08/08 of 08 began at 08:08 a.m. to the sounds of the theme from 2001, A Space Odyssey, as we embarked on this new journey. While this picture was a little later, that first meeting had 25 members representing virtually every area of the hospital, all who were appointed by our CEO, Nancy Farber. Today, we still have 8 charter members active on our committee. There's a little bit of confusion in the hospital about the Green Initiative, which is a hospital department complete with a budget, and the Green Team, which is a volunteer committee who meets monthly, develops goals, gets things done, and exchanges ideas. Either way, we get to take credit for other people's work. The Green Initiative was placed on the institutional agenda for 2008 by Nancy Farber. As mentioned, we had our first meeting 10 years ago, and since then, we've made a lot of progress. This is our third update to you, and it's going to be a quick trip through a nonlinear scrapbook. We have a lot of obstacles in greening healthcare. One example is infection control. In order to fight the ever-evolving bugs, we need to have more disposables and harsh chemicals. Washington Hospital is committed to the health and safety of our patients, employees, and the public. So we have a perpetual balancing act. The UN defined sustainability in 1987 as meeting the needs of the present without compromising the ability of future generations to meet their own needs. And in 2005, the World Summit said, sustainability requires the reconciliation of environmental, social, and economic demands, the three pillars of sustainability. And that brings us to the triple bottom line, where everything we do has to land in that sweet spot of people, planet, and profit. The Institute for Healthcare Improvement has their triple aim, which aligns with this very nicely. Healthcare sustainability is definitely much more than just a blue bin by the copier. It's directly related to quality, risk management, safety, patient experience, employee satisfaction and wellness, positive public relations, community benefits, and cost savings. In other words, by focusing on and investing in sustainability, we can realize returns on investment on multiple fronts. Healthcare comprises 18% of GDP and climbing. It consumes 8% of the U.S. energy and emits 7% of U.S. greenhouse gases. Typically, we are the top water users in a community and produce more than 30 pounds of waste per bed per day, while nurses and EVS staff have highest work-related asthma rates. Our mission in healthcare is to protect and restore human health and well-being, or at the very least, do no harm to our patients, employees, or the community. To help us on this journey, we became charter members of Practice Green Health. Their mission is to educate, motivate, and engage healthcare institutions and professionals about environmentally sustainable programs that improve health of patients, staff, and community. They have 10 sectors that they are focused on, and they're all listed here. These are also the 10 sections of the award application that I'll tell you about in a few moments. Our Green Team mission statement is to create a collaborative force to facilitate stewardship of our resources by promoting and facilitating ideas and solutions to help improve the ecological well-being of our community and institution. The summary of our scope is to learn, act, and track projects that fit the triple bottom line and to help educate our employees and the community. We had a contest for a tagline, and it is Planet-Friendly Healthcare. While most years we do rather well with our goals, this year we weren't quite so successful. We wanted to focus on transportation, but we've had to push that out a little bit until next year. We focused on paper and did get IT to confirm that all the copiers are defaulted to double-sided printing. And we've educated through Currents to help reduce overall paper consumption. We have a brochure that we update frequently and make available to new employees as well as the public. Some people may not be sold on this whole green thing, and I think this cartoon sums it up. If you can't read it, they are at the climate summit, and someone in the audience asks, what if it's all a big hoax and it would create a better world for nothing? But you, the board of directors, get it. You proved that in November 2011 when you adopted the Statement of Environmental Goals, spelling out the hospital's environmental principles. In 2011, we were awarded the Making Medicine Mercury Free Award. We can only win this one time. During the process, we had to make a lot of changes, including these, and a lot were to keep mercury out in the future. It's worthwhile noting that fluorescent lights, including the CFLs, the twisty bulbs, all need to be recycled properly and not in the trash. Practice Green Health has an awards program, but before I talk about that, I would like to share a few facts. There are approximately 5,600 hospitals in the United States, and about 1,100 of those are members of Practice Green Health. They awarded 330 Partner for Change awards in 2018. That means only about 6% of the hospitals in the U.S. received this honor. The application is very long and detailed. It takes a team and several months to complete. The PDF at the end is over 100 pages long. It's a great self-assessment tool, and it helps stimulate ideas for us. Each year, it keeps getting tougher. Here are a few of our awards, and a few more. When we win, we celebrate our successes internally and outside to the entire community. We also have garnered several other awards, including the Stop Waste Business Efficiency Award. We've been on the Union Sanitary District Honor Roll for many years and have been recognized for our composting efforts by the City of Fremont. About a year ago, I was honored to be appointed by the mayor to sit on the Fremont Sustainability Commission as the business community representative. Our medication take-back program was a joint effort with Union Sanitary District and garnered national attention. I was honored to be a speaker about our program on a national webinar. Union Sanitary District Board of Directors thanked the hospital with a resolution, and the Alameda County Board of Supervisors gave us a commendation for it. As part of our outreach, we have presented our program to many groups, including quality engineers, Rotary, and schools. We celebrate our accomplishments wherever possible, including when the hospital newsletter went green by printing on recycled paper in 2009, and then later went almost exclusively to PDFs. One accomplishment that we're particularly proud of was the water savers on the sterilizers. Sterilizers are very important machines in a hospital. Ours use a lot of water, and these devices drastically cut that usage by reusing the non-contaminated water. You can see how this project saves us more than 2,500 gallons per day for a total of almost 942,000 gallons per year. This is an annual savings of $10,000, and they paid for themselves in less than 3 years. Speaking of water, one awesome reuse project was River Rocks. When the foundation was being dug for the Morris Hyman Pavilion, Critical Care Pavilion, they found an old riverbed full of rocks. Robert Alfieri, our chief of facilities, knew what to do with them. He had the rocks used in our landscaping to reduce water and to cover some difficult areas. We developed a campaign with the logo, signs, and stickers to educate employees and the community about water use. And Alameda County Water thanked us. When we were analyzing the data in the Practice Green Health Awards, we saw an amazing story of reduction of water consumption. We've told our employees that changing to fonts such as Century Gothic can save money by reducing toner usage, how to get discounts on solar panels and EV cars, and how to help the hospital become greener. And we recognize departments who get caught in the act of being green. We educated and celebrated when we got the clean air vehicle parking spaces and the EV charging stations. Since 2015, we have staffed an Energizer station for Bike to Work Day in May, and we hope to see you all there next year. Our IT team took the idea further this year and organized the lunchtime bike ride around Lake Elizabeth. We've been featured in several mailings in the community, including the annual report. Some of our bigger accomplishments include finding second lives for electronics, furniture, and office supplies, the awesome food composting in food services. We've updated and replaced machines with ones that have better energy and water efficiency. We donate medical equipment. We have a shuttle to the ACE train station and WageWorks commuter benefits for our employees. The cafeteria has eliminated all styrofoam and uses compostable takeout containers. We underwent energy audits that resulted in energy savings. We use integrated pest management program to reduce chemicals. Environmental Services uses microfiber mops that use less water, are better for the employees, and they clean better. We have some water-free urinals. The laundry equipment reuses the final rinse of one load for the first rinse of the next. And the Morris Hyman Critical Care Pavilion is being built with LEED certification in mind. Our food and nutrition services are rock stars. They have stepped into the national spotlight, presenting webinars and calls, sharing and educating wherever possible. They were even finalists in the Healthcare Without Harm recipe contest recently. They're not only pushing the envelope, but spreading the good word about sustainable and local foods. When they lost their herb garden to the construction site, they repurposed the old smoker shack and made it into a hothouse for herbs and vegetables. They are so committed to their local farmers that when the cafeteria was recently refurbished, they put this map on the wall featuring 2 of their farmers. We've had some other successes, including zero waste employee lunch, where everything was composted or recycled. The registration clerks wear a uniform that's made of recycled bottles. We were featured in an award-winning video titled Inside Washington Hospital, The Green Team, that's available on the website. This photo was from a tweet about our green team. In April 2017, we joined the Spare the Air employee program. We're hoping to do a lot more with them in the near future. Our operating room is another rock star for us. SPD and the OR use a lot of material called blue wrap for sterilization. This stuff is really tough to recycle, and the OR makes it available to take home as drop cloths, pet mats, and other things like that. To reduce blue wrap, our sterile processing department uses a lot of reusable sterilization containers like these. The OR also recycles clean paper and plastics from their supplies. We started reprocessing single-use devices in October 2015. Since then, we've reprocessed more than 73,000 devices and saved $724,000, reduced red bag waste, our most expensive waste, by 11,000 pounds, all while improving patient safety. We have many different recycling programs in use here at the hospital. One of these is single-stream recycling, like the one you probably have at home. We started this program from a grant from Stop Waste in 2009. We publicized the rollout and the rules, and at one point, we had some issues. We met with the City of Fremont and Republic Services, our waste hauler. Then we took a field trip to the business recycling section at the transfer station, where they actually sort the materials. Our team has had booths at health and safety fairs, the concerts in the park, and the Fremont Festival. But our marquee event is Earth Day. This is our humble beginnings in 2009, a small table in the cafeteria. We later moved and then eventually partnered with the City of Fremont. And here are a few photos of this year's event, both inside and outside. This is our Green Team booth, and the team from Washington Hospital and the City of Fremont who start planning this April event in November. And the mayor always makes it a point to drop by. A few years ago, we started actually tracking attendance. Celebrate this? We certainly do. And we get a little more publicity for it. This slide is from the Practice Green Health Benchmark Report Card. I know you can't really see any details, and that's okay for now. The data is comparing us to other award applicants. The black dots compare us to everyone, and the red squares are only our own cohort of non-academic institutions. I want you to notice how many black dots are on the right of the chart. That's where we want to be. The further to the right, the better. It also shows that we still have room for some opportunities for improvement. Our solid waste last year actually increased. Overall, our recycling went in the wrong direction, although we still beat the median with 31%. This and several charts following show our performance the last several years, the most recent in purple at the bottom. It's possible that the missing recycling bins that have now been replaced and improved pickup frequency will help increase our recycling next year. This slide is very interesting. It shows our regulated medical waste for our benchmark year of 2007, which by 2017 we had cut in half for the same cost. Last year, we saw a decent reduction of 20 tons and further savings. We created 0.9 pounds of regulated medical waste per staffed bed per day, which is very close to the 90th percentile. One component that has helped is the reusable sharps container program that we rolled out in 2010, thanks to another grant from Stop Waste. We projected we would save 9 tons of plastic per year. According to our vendor, in fiscal year 18, we diverted 14.5 tons of plastic for a savings of $660,000. Our total waste went in the right direction, and our 40 pounds of total waste per patient day beat the median of 45 pounds. We have many different waste streams. This total waste is comprised of 4 categories: solid waste, recycling, regulated medical waste, and hazardous waste, each having their own unique costs. This chart shows a breakdown percentage. This second chart shows the exact same totals, but by cost. Those little percentages become a much bigger piece of the pie. Here's a few green facts for you. Half of our spend on cleaning chemicals are certified green, and half of our office supplies are purchased with recycled content. And only about 5% of our spend on hand hygiene products contain triclosan or triclocarban, both chemicals of concern. And the shift from paper to CD for new employee handbook saves 488 pages per new hire and $5,000 in paper costs per year. We've been tracking paper usage for all 10 years. I'll bet you can guess when we implemented the electronic medical record. We moved to 30% post-consumer recycled copy paper in 2015. We calculated this would save 353 trees, the energy of 2 homes per year, enough water to fill 1/4 of an Olympic-sized swimming pool, and half a loaded garbage truck. In fiscal year 18, we purchased 38,000 reams, and this recycled paper does cost about 6 cents more each. That means we saw a slight increase of $2,300 for the year. Environmentally preferable purchasing is the process of selecting products and services whose environmental impacts have been considered and found to be preferable to those of comparable alternatives. We have several reusable containers and products in use here. I've already mentioned a few. One additional item is reusable totes. Our pharmacy, laboratory, and food service all use these. Reusable totes replace cardboard boxes that distributors pack their deliveries into. Totes eliminate this extra waste. Back when the central utility plant was being built, the contractor noticed that we had called out for incandescent lights. They did the analysis and replaced the lights with CFL bulbs for a savings of $150,000. This project was used as a case study by Practice Green Health. And now I'd like to give a quick shout out to my vice chair, Gisela Hernandez, who has become a great partner on this journey. And finally, thank you for allowing me to share our awesome sustainability programs, the Green Initiative and the Green Team.
Thank you very much, Paul. Are there any questions from the board?
Yeah, just looking back at what you've done over the last 10 years, it just boggles my mind what you're going to do over the next 10.
Very, very impressive. I think if we all in our own individual homes did anywhere near as well as you've done here, we'd see some tremendous progress. Thank you very much.
Thank you.
I'm very proud of our green team and the leadership. Paul, thank you.
I like the music. We'll move now to a consideration of the minutes for July 11, 16, 23, and 25. Do I have a motion for that?
Mr. President, I move for approval of the minutes from July 11, 16, 23, and 25.
And I'm looking for a second.
Second.
We have a motion and a second. Dee, if you'd take the roll.
Director Stewart.
Aye.
Director Wallace. Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Thank you, Dee. We'll now look for communications. Do we have any oral communications today?
No, we don't.
Thank you. We'll now move to our written communications. Tonight we have Dr. Killaroo with us, who's
Yes.
taking the place of Dr. Choi. Dr. Killaroo.
Thank you. We have 8 new applicants. Dr. Srikant Ambadi, Internal Medicine, Dr. Sonia Jarani, Internal Medicine, Dr. Mark Laradel, Internal Medicine, Dr. William McNutt, Intensivist, Critical Care, Dr. Gurinder Singh, Internal Medicine, Dr. Michael Stevens, Internal Medicine, Dr. Almario Yanga, Internal Medicine, and Dr. Jessica Zigman, OBGYN, are the new members. Except for Dr. Zigman, all the others are also asking for temporary privileges. For reappointments, we have a total of 32 two-year reappointments. Dr. Bunny Paulson, Dr. Bauer, Dr. Belay, Dr. Kabibi, Dr. Chawla, Dr. Chi, Dr. Cheng, Dr. Cole, Dr. Curran, Dr. Dastiga, Dr. G, Dr. Giddens, Dr. Halimi, Dr. Shu, Dr. Hussein, Dr. Haider, Dr. Kim, Dr. Kompella, Dr. Lam, Dr. Lin, Dr. Raj, Dr. Ranchod, Dr. Sharma again, Dr. Soleimani, Dr. Spira, Dr. Srivastava, Dr. Sood, Dr. Sundar, Dr. Wang, and Dr. Wong. And we have 4 one-year reappointments: Dr. Dickler, Dr. Erasmus, Dr. Hussein, and Dr. Reen. We have several doctors that are transferring in staff status category: Dr. Curran, Dr. Karen Goda, Dr. Nguyen, Dr. Raj, Dr. Soleimani, and Dr. Wood. Of these, Dr. Ahmed, Dr. Soleimani, and Dr. Wood have completed their proctorship and are advancing their staff status category. Dr. Ariola and Dr. Mintz had completed their proctorship but are not quite eligible for change in statuses yet. Dr. Ranchod is asking for additional privilege. Dr. Hussein, Dr. Wong, and Dr. Ranchod are also removing privileges that are listed. And finally, we have 2 resignations, Dr. Belton and Dr. Mitarai.
Thank you. We have a motion for approval of the medical staff motion.
Mr. President, I move for approval of the credentialing action items as presented by Dr. Killaroo.
Second.
We have a motion and a second. Dee, if you'd take the roll, please.
Director Stewart.
Aye.
Director Wallace. Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Thank you, Dee. We'd now like to hear our Service League report from Jeannie Yee.
Good evening. Greetings from the volunteers. I don't know where July went, but it's good to be with you all again. In July, busy month, wonderful to have the high school students and college students. And because of them, volunteers were able to give 3,385 hours of service last month. So we like to see that spike, more patients being served. Also, last month I got our newsletter out, and Mr. Kelly's presentation on green is really challenging for us because we have so many senior members. We still have to print that newsletter. They don't have email, but that's okay. We've been cutting down as much as we can and emailing as much as we can. And last month, as you know, our library, the Health Resource Library, closed, so several of our volunteers had to look for new places to staff. But one of the neat things that I learned were 3 of the volunteers, I call them my bookends, because they were there when the doors opened 19 years ago, and they were still there to help with the closing of the library. So it's neat to see volunteers that stay with the service and invest in it and bring great success. So it's been a great month.
It's hard to see the library close.
Mm-hmm.
I remember getting ready to open it.
Yes.
And it just seems that people get their information a different way now.
Yeah.
And I think everybody knows about my passion for books and for reading. So for me, that was very painful. And I deeply appreciate the volunteers that helped our hospital with that library all these years.
They found it very rewarding.
Thank you. Our medical staff report from Dr. Killaroo.
Yes, so we have a grand total of 593 members in the medical staff, of which 351 are active. We have 3 ambulatory and 20 allied health, 3 administrative and 20 allied health professionals in the medical staff as well.
Thank you. Approaching the 600 mark again.
We keep hovering around that mark. And I think we may get close to it because next month we have about 10 new applicants. So assuming no resignations, we should pass the 600.
Be careful. Thank you. Anyway, Nancy, we hear our hospital calendar.
We could start with the video shoot. Thank you.
Past health promotions and outreach events. The 2018 Central Park Summer Concert Series presented by Washington Hospital Healthcare System kicked off on Thursday, July 12th, with an estimated attendance of 3,500 each week. This free 6-week concert series is open to the public and will be held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. Washington Hospital will be providing health information and health screenings during this 6-week concert series. On Friday, July 13th, as part of the Speakers Bureau, Dr. Victoria Leapart, gynecologist, presented Nutrition Myths to residents at Acacia Creek Assisted Living Facility. 43 people attended. On Tuesday, July 17th and Wednesday, July 18th, Washington Sports Medicine hosted sports physical clinics for local high school students. Each student received an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Medical Director Dr. Russell Nord, along with other providers from the Washington Township Medical Foundation, provided the examinations. Athletes also received orthopedic screenings by certified athletic trainers. The event also included a health fair highlighting the benefits of pre- and post-exercise nutrition and the dangers of smoking. Each athlete paid $20, which will be donated to the schools for sports medicine supplies. 94 students received sports physicals. Also on July 17th, Dr. Jeannie Ahn, nephrologist, presented Chronic Kidney Disease, Frequently Asked Questions. 39 people attended. On Thursday, July 19th, as part of the Women Empowering Women series, Dr. Victoria Leapart presented Navigating Health and Aging, Discussion on Preventative Screening. 15 people attended. On Tuesday, July 31st, Dr. Catherine Dow, cardiologist, presented Atrial Fibrillation, AFib, What You and Your Family Should Know. 62 people attended. On Thursday, August 2nd, as part of the Diabetes Matters program, Anna Mazet, registered dietitian and certified diabetes educator, presented Indian Asian cuisine. This presentation explored modifying traditional recipes to make them healthier without losing their distinctive flavors. 20 people attended. On Tuesday, August 7th, Denise Lynch, RN and stroke program coordinator, and Elisa Curry, physical therapist and rehab clinical programs coordinator, presented Recovering After a Stroke, a Patient and Family Guide. This seminar provided an overview of the recovery process following a stroke, including home adjustment and physical conditions after a stroke. 15 people attended. Upcoming health promotions and community outreach events. On Thursday, August 16th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present How to Sleep Your Way to Better Health. On Saturday, August 18th, in celebration of babies who were cared for by a team of dedicated neonatal nurses and neonatologists, the Special Care Nursery will host its second annual SCN reunion. Former SCN patients and their families are invited to attend a fun-filled event from 11 a.m. to 2 p.m. On August 21st and 28th, Melissa Reyes, RN, will provide a two-part education series on stroke. Part 1, Stroke Prevention, will educate community members about prevention, symptoms, and what to do if you are experiencing signs of a stroke. Part 2, Life After Stroke, is an overview on how to better understand your condition and how to move forward after a stroke. Did you know patients with peripheral vascular disease, PVD, have a higher rate of early mortality? If left untreated, patients with PVD can develop serious health problems, including heart attack, stroke, renal artery disease, and amputation. Diagnosing PVD can be as simple as performing a painless, non-invasive Doppler ultrasound investigation of the patient's leg circulation. On Saturday, August 25th, from 10 a.m. to 1 p.m., Washington Hospital will host a PVD screening event. This free screening includes a Doppler study and an interpretation of results. This event is co-sponsored by Fremont Bank Foundation. Pre-registration health questionnaire is required. Call 800-963-7070 to schedule your appointment. Ordinary infections can become so severe they can cause an overwhelming immune response called sepsis. Sepsis is a life-threatening condition. On Wednesday, August 29th, from 1 to 3 p.m., Dr. Shekhar Srinivas, Emergency Medicine, and Dr. Rohit Arora, Intensivist, will present Learn the Signs and Symptoms of Sepsis. On Wednesday, September 5th, from 6 to 8 p.m., Dr. Sarah Wortman, vascular surgeon, will present Peripheral Vascular Disease, What You Need to Know. On Saturday, September 15th, community members are invited to the Morris Hyman Critical Care Pavilion Open House. The pavilion will house our new emergency department, critical care units, and medical surgical patient rooms. Here is your chance to see and learn about our new state-of-the-art, seismically safe, and family-centered pavilion. Join us on this special day and tour our beautiful new 224,800 square foot healthcare facility. See features that include all private patient rooms, use of natural lighting, a 3-story atrium, and a special tribute to community leader and advocate, visionary, philanthropist, and Fremont Bank founder Morris Hyman. Tours are available between 10 a.m. and 2 p.m. Reservations are required. Please call 510-791-3417 to book your tour. On Saturday, October 27th, Washington Hospital and the Taylor McAdam Bell Neurosciences Institute will host the Advances in Neuroscience's 9th Bay Area Symposium. Internationally recognized experts will discuss a wide range of topics, including management of opioid dependency, minimally invasive spine procedures, brain mapping technology, concussion diagnosis, and advances in neurosciences technology, care, diagnosis, and treatment. The program coordinators are Dr. Sandeep Kunwar, neurosurgeon, Dr. David Larson, radiation oncologist, and Dr. Moses Tagioff, neurosurgeon. Speakers include Dr. Edward Chang, professor of neurological surgery and Bose biomedical investigator, co-director, Center of Neural Engineering at UCSF and UC Berkeley. Dr. John H. Chi, director of neurosurgical spinal oncology, Brigham and Women's Hospital, associate professor, Harvard Medical School. Dr. Richard Fessler, professor of neurosurgery, Rush University Medical School. Dr. Jonathan Katz, medical director, Forbes Norris, MDA, ALS, Research and Treatment Center. Dr. Angela Lumba Brown, clinical assistant professor, emergency medicine and pediatrics, Stanford University. Co-director, Stanford Brain Trauma Evidence-Based Consortium. Dr. Sharon Shaw, clinical associate professor, neurology and neurological sciences, Stanford University. Dr. Mark Schumacher, professor and chief, Division of Pain Medicine, UCSF School of Medicine. And from the Washington Hospital Taylor McAdam Bell Neuroscience Institute, Dr. Sandeep Kunwar, neurosurgeon. Dr. Eldon Eichbaum, neurosurgeon. Dr. Jeffrey Thomas, cerebrovascular and neurointerventional surgeon. Dr. Jack Rose, neurointensivist. Dr. Sharon K. Singh, neurologist. This symposium is intended for clinical providers. To register for the symposium, call 510-791-3417. Bay Area Healthier Together. Washington Hospital and ABC7's Bay Area Healthier Together is continuing to raise awareness and educate the public about health issues and healthcare resources. In the month of July, Bay Area Healthier Together featured stroke prevention, signs of a stroke, and vascular neurosurgery. More information is available at bayareahealthiertogether.com. The Washington Hospital Healthcare Foundation Report. On Saturday, October 13th, the Washington Hospital Healthcare Foundation will host the 32nd Annual Top Hat Dinner Dance. This year's gala will be chaired by Marcia Bedella, Dr. Carmen Akawili, Medical Director of the Intensive Care Unit, and Dr. Kadir Halimi, Medical Director of the Emergency Department. Proceeds from the evening will benefit Washington Hospital's new intensive care unit in the Morris Hyman Critical Care Pavilion. The Foundation accepted sponsorships for the gala. Thanks are due to the following returning sponsors: Fremont Bank, Professional Home Care Associates, Neurosport Rehabilitation Associates, Gonzalez and Kozenchenko, Palo Alto Medical Foundation, UCSF Health, Valak, and Bank of America Merrill Lynch. Washington Hospital Employee Association, WIA. WIA is currently holding a backpack challenge for the Back to School Drive, benefiting those served by Abode Services and SAVE. Staff, physicians, and volunteers are donating items to fill a backpack for a student in need. The students range from kindergarten to college. On August 4th and 5th, WIA held their biggest fundraiser of the year. During the Fremont Festival of the Arts, employees requested a $5 donation for festival attendees to park in the Washington West parking lot. The event raised $6,157. Proceeds will benefit charitable projects and organizations in the district. In response to an urgent request from the American Red Cross, on Friday, September 7th, from 12 to 6 p.m., WIA will hold a blood drive with the American Red Cross in the Anderson Auditorium at Washington West. To book an appointment, go to www.redcrossblood.org or call 800-733-2767. Washington on Wheels WOW Mobile Health Clinic. After several months helping in Santa Rosa in response to last October's wildfires, the WOW Mobile Clinic returned to our healthcare district. After routine maintenance, it is ready to once again provide quality healthcare services primarily to uninsured and underserved district residents. Starting August, WOW will begin visiting sites throughout the district. Some screenings are free and other services are provided on a sliding scale from free to low cost. For more information on the mobile health clinic, please call 510-608-6175. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's About WHHS was July's most viewed webpage with 38,315 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth Channel 78. During the month of July, Washington Hospital's cable channel 78 InHealth captured new programming, including a caregiver program titled Codependency and the Caregiver, and a health and wellness program called Chronic Kidney Disease, facts, questions, and answers. In addition, InHealth aired a caregiver program titled Mindfulness Meditation for the Caregiver, a health and wellness program called Fun Fresh Summer Foods, a Diabetes Matters program on iHealth, and the July District Board of Directors meeting. InHealth also aired a special public service announcement on whooping cough. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070, and please follow us on Facebook, Twitter, Instagram, and YouTube.
Before I introduce our August Employee of the Month, I wanted to take a moment and read a letter to the Board of Directors, to our management team, and to all of our employees on all 3 shifts, weekdays and weekends. We're in a busy time as we get ready to occupy our newest addition to the healthcare system, the Morris Timon Pavilion. And people understandably are working harder than ever to get that done in a safe and orderly way. And sometimes we focus on the pile of work that's on our desk and forget to lift our heads up and see what's around us. One of our patients helped all of us do that. And I want to share her letter with the board and our hospital community. First, an apology. I should have written this letter much sooner. Your people worked hard and did such a great job. I'm sorry it's taken so long to let you know. This past May 11th, I had back surgery performed by Dr. Erasmus at Washington Hospital. From the pre-op appointments to the post-operative care in 6th floor west, the entire process was amazing. 5 stars, 5 out of 5. The pre-operation interview was thorough and very well handled. I wish I could remember the woman's name. She was so kind. The phlebotomist who took my blood was so efficient, I never felt the needle go in. A first. Pre-op on the day of surgery was handled by an RN by the name Paula. She explained everything thoroughly and completely calmed any stress about the upcoming operation. The actual procedure was delayed through a miscommunication with one of the team members, something Paula and her crew handled with complete professionalism. They made sure I wasn't in distress or worried about the delay, which I wasn't thanks to them. Dr. Erasmus's team could not have been better. They introduced themselves to me one by one and let me know what to expect in the operation room. Dr. Erasmus checked on me a couple of times. He is really a wonderful physician. The surgery went well, as far as I could tell, and the next thing I knew, I was in a room on the 6th floor. The entire time I was in my room, I felt very well taken care of. Katie, the RN, in particular, was amazing. The examinations were thorough, well explained, and done with a level of care and patience I hadn't received in other hospital situations. The physical therapist who helped me with the first efforts at walking the hallways was very kind and also very patient. I must compliment the food service folks. Dr. Erasmus put me on a strict, low-carb diet immediately. I expected limited food and lack of flavor, but the meals were excellent. My only disappointment was not being able to have the Mother's Day crepes, but crepes aren't low-carb. From your nursing staff through your housekeeping staff, everyone had a wonderful attitude and welcoming smiles. They all did their jobs exceptionally well and did their utmost to provide the best of care. My husband and I could not have been in better hands. Again, please accept my sincere apologies for allowing time to slip by before sending this. My thanks go to all of your employees and my confidence that if I ever need to go to Washington Hospital for surgery again, I will have a happy and successful experience. And I just thought this was a time when everybody's working so hard they could use a little praise. And she certainly gave us high praise, and I'm very grateful for her letter. I won't disclose her name. Patient confidentiality prohibits that, but I will respond to her personally, and I just felt this was a letter to be shared. Our employees work very hard, and they deserve to hear this. Okay, now I want to introduce our Employee of the Month, Nellie Tate. Nellie was born and raised in the Philippines. When she left at 17, she had no idea that she would make a home in Hawaii, Indiana, St. Thomas Virgin Islands, Dallas, Texas, and the state of Washington before arriving in Fremont and Washington Hospital. In 2001, Nellie joined the Washington Hospital as a confidential clerk. After only 3 months, she became a business assistant where she now covers nuclear medicine, EKG and echo, non-invasive cardiology, and pulmonary and respiratory rehab departments. Her background as a nuclear medicine technician and her unflappable organizational skills have made her obviously a very valuable asset to the hospital. She says, and I quote, "I enjoy helping to navigate appointments and procedures for patients. Coordinating multiple schedules can sometimes be complicated, but our physicians, technicians, and patients are wonderful to work with and usually express gratitude for my work." The staff members that she has worked with over the years have had many opportunities to appreciate her work. She has never been late or called in sick in 17 years. That's quite a track record. She dismisses this amazing accomplishment with a nonchalance. "I guess I'm old school. I was raised to be at work every day on time, and it just stuck with me." Nellie recently took on the responsibility of pulmonary rehab discharge planning. She works with the patients and outside facilities to create a plan to best serve our patients. The patient-first ethic is clear in every aspect of her work. As a single parent, Nellie has always balanced her work with the needs of her daughter, Tiffany. When Tiffany was 14 years old, they both felt a high school education in California would be a benefit, so they moved to Fremont, California. Tiffany attended Kennedy High School and went on to the University of Southern California. I know you'll appreciate that, Bill. She became an architect and now works on commercial projects. Tiffany and her husband recently gave Nellie the most valuable gift she could imagine, a granddaughter named Avery Sky. And though she tears up at the thought of possible retirement over the next couple of years, the idea of spending more time with Avery quickly brings a smile to her face. Being a grandma is pretty nice. It really is. And so I'm very pleased to present Nellie to our board of directors and our community.
Well deserved. It's always a pleasure to deal with Nellie.
Yeah, that's good to hear.
Yeah.
Thank you.
Yeah.
Thank you, Nancy. We'll now have a lean report on obstetrics inpatient value system from Dr. Bettina Kirkjohn and Dorothy Skull, RN.
Let me give quick bios for the two of them. Dr. Kirkjohn has spoken before the board before. She's been at Washington Hospital since 2001. She did her undergraduate work at Stanford University, medical school at UC Irvine, and went on to do her OBGYN residency at Kaiser in Oakland. She joined Washington Township Medical Foundation in 2011 from private practice. She started in the Kaizen promotion office in 2016 and additionally serves on several medical staff committees. Dorothy Skull is a registered nurse with a bachelor's degree in nursing. She began her career at Washington Hospital in 1981 as a bedside nurse in the birthing center. She holds specialty certifications as an inpatient obstetric nurse. She has grown professionally in her 37 years here and is currently the nurse manager for our birthing center. So I will let Dr. Kirkjohn and Dorothy take over.
Thank you. So this is just a little summary of our OB and patient process that we've had in our lean journey. Our birthing center lean vision is committing to our patient first ethic, which aligns with our mission statement, understanding and analyzing our current state. Focusing on patient care services, maximizing value, and minimizing non-value added steps. Value stream mapping, identify waste and use lean tools to improve the process. Finally, to redesign our future state, maximizing value from the patient's perspective. It has been amazing, continuously improving transformation on the birthing center. In my 37 plus years at Washington, I've seen a lot of change. Clearly, this lean vision has been the most empowering, satisfaction pleaser for our patients, and smoother, more efficient workflow for our nurses. Our current state consists of about 1,800 deliveries a year. Washington Hospital Level 2 Nursery partnered with UCSF, participated in the Center for Medi-Cal and Medicaid Services 16 Prime Project initiatives to improve patient outcomes. Our Quest for Zero with our Beta insurance carrier, we completed both Tier 1 and Tier 2 for 3 consecutive years. These tiers consist of exercises challenging our critical thinking skills, education on current best practices, and improving our skills with drills on our unit on emergent situations that can arise when caring for the laboring mom and her unborn child. And we opened up our prenatal diagnostic center in December of 2017. We began our lean journey in September of 2017. We were able to understand our current state and do our value stream mapping. Then on to plan our 5 workshops with our vision of the redesign, of the redesign of our future state. The workshops included 5S of our 2 West and 2 South clean utility rooms, OB, OR number 1, and our non-stress testing room. Our second workshop included our admission process. The third workshop was on communication on the second floor, including our handoff between labor, postpartum, and newborn staff. Our fourth workshop was on patient discharge, which included the redesign of our discharge booklet that we give to our patients. This week, we're in our 5th workshop, 5S of our OB recovery room, and incorporating lean management in our everyday huddles. Our first workshop was 5S. We chose our OB-OR room 1, non-stress testing room, 2 West and 2 South clean utility rooms. We organized supplies, separating mom versus baby items for quick access, and established appropriate PAR levels. We gave our equipment a permanent home with pictures on the wall to show the staff where to replace the equipment after each use. These are before pictures of our 2 West clean utility room. The left picture shows a delivery cart obstructing the supplies used to set up the cart. No clear organization of the supplies, and on the right, lots of cables and cords. In our OB operating room, we consolidated items from 3 cabinets down to 2, allowing the removal of 1 entire cabinet. We labeled everything and are using Kanban cards for easy restocking. We now have separate supplies for mom and baby in our 2S clean utility room with clear signs and labels. Right after we completed our 5S of the clean utility room, we asked one of our nursing students to find some baby diapers. We only told her that they were in the clean utility room. She was able to locate the diapers immediately, just as fast as one of our regular staff. Everything clearly labeled and accessible. I would now like to invite Dr. Bettina Kirkjohn up to continue on our journey.
Thanks, Dorothy. So thank you so much for inviting us to share our lean journey with you and let you know what we're doing in the birthing center. I'm an OBGYN by training, and so I've been part of the birthing center for the 17 years I've been at Washington Hospital. And so it's been a real privilege for me to be a participant in the lean journey that the birthing center is taking. As Dorothy mentioned, our second workshop was on the admission process. And our patients in the birthing center are a little bit different from the other patients that come into the hospital. Our patients plan to visit us at the hospital. They know they're coming in. They know often, 9 months in advance that they're going to be seeing us. And they're not coming in because they're ill. They're coming in because they're sharing this really momentous occasion in their lives with us and allowing us to participate in the care during that time. And sometimes they'll come in multiple times. Sometimes they'll be coming in for other services, for services related to their pregnancy or routine testing, or sometimes they have a couple of false starts and come in a couple of times for labor checks before they actually have their baby. So when we looked at our processes, we found that there were some things that we were doing that were great, but we were not really making the best use of them. For example, we have a pre-admission appointment where the patient will come in and have their intake done, but also get some teaching education. We found we really weren't making the best use of that appointment. And there was a lot of rework that was happening for patients who were coming in multiple times, having the same questions asked several times. So we did a few things. We optimized our pre-admission appointment. We made a new flyer that lets people know the benefits of that. And we developed a new process for scheduling to streamline, to make it a lot easier for the patients to actually get those appointments scheduled. We streamlined the questions that the RN was asking. We have this great medical record, electronic health record called Epic, which does a lot of stuff for us. And so we wanted to really take advantage of data that was already in the system and not having to review or ask the patient questions multiple times. And we also streamlined access to that data so that when a patient would come in several times, we had a little glitch with our system where that data that was entered wasn't easily available to the nurse. So we really changed that system. We also really wanted to streamline the entry of the patient into the birthing center because they can sometimes come in several times, but we did not want to do that at the expense of security. Security in our unit is extremely important to protect our babies and our moms. So one of the things that was really fun about this workshop is we actually engaged our security team, we engaged our admission team to really get them involved in how do we streamline the process for the patient, but at the same time not jeopardizing security in the birthing center. So that was a really collaborative effort. Our third workshop was on communication. As Dorothy said, we really focused on communication within the nursing unit of our personnel. Like many areas of the hospital, we have handoffs, and these handoffs can occur when there's a change in shift from one nurse to another, or it can occur when the patient has a change in their phase of care. For example, they're laboring and then deliver. And we have a special circumstance in our unit, again, different from other units, where moms come in as just mom, and then they have their baby, and now there's two patients. And these two patients really have to have coordinated care together. Sometimes there's just mom, sometimes the mom and baby are being taken care of by different people, sometimes they're being taken care of by the same people. So we found, again, that some of our processes were a little bit inconsistent. So we, again, trying to utilize our great electronic health record, we developed a new handoff tool. On the birthing center, we were not very green. We were using a paper tool that, first of all, it was paper, and second of all, it required a lot of work for the nurses to actually fill out this tool. And so we took advantage of our Epic system, and we pulled all that information from Epic into an electronic tool that then the nurses have all this information at their fingertips. And I know this just sounds like a really easy fix, like, oh yeah, you just pull the information in from Epic, but it was actually really complicated. We had to really understand what information did we want, what information did we need to hand off the patient clearly and successfully, and then where does that information live in the electronic health system, and pulling it in a fashion that the nurses could visually say, oh yeah, this is the information that I'm looking for to communicate. And we actually did several iterations of this where it was developed, it was used, and then the nurses gave Dorothy feedback to say, we like this aspect, but we don't like this aspect. We met with Epic again, got the feedback from the nurses, and then they redid the tool again for us. And again, really nice continuous improvement process there. We have been working on our discharge process. Again, I know every unit says, "Oh, my unit is so complicated," but we really do feel that we've got some special considerations in our unit. Again, a lot of amount of education. We want to send our moms home really prepared for this new phase of their life. So we want to really give them all the education that we can. And our moms there's lots of things that our mom and babies do have done before they go home. Many tests that the baby has done that we want to make sure we don't send them home without having done those tests. And some of these tasks are, done by other departments. For example, the health information will process the birth certificate. Sometimes, we have things that are done by outside vendors. So coordinating all those people is really sometimes a challenge. So we developed a tracking tool for the nurses so they could see at a glance the status of these different tasks that need to be done. So they have one screen that they can look at and say, yeah, we know that these 5 things are done, but these 5 things still need to be done. And we also developed some tools for our patients so that they could understand the status of their process in the delivery, what was going to happen for them so they could be a participant in that care. And then also some tools to help them fill out the birth certificate information, which if you guys have ever seen it, it's from the county and it's extremely complicated. So giving them some, like a little cheat sheet to help understand how to help fill that out. As Dorothy said, we're on our 5th workshop. We're actually in the process of doing that workshop today. So if Dorothy and I look a little tired, it's because we've been working really hard this week. And when we were trying to plan this workshop, we were trying to really think about what did we need on the birthing center. This was our last opportunity for Kaizen, which is continuous improvement workshops. And so we decided we really wanted to finish the 5S because we hadn't had a chance to do the recovery room and the delivery rooms. And 5S is such a big satisfier for staff because staff loves having what they need, where they need it, when they need it. But then we also really wanted to be thoughtful about, we're done with our 5 workshops, but we really want to foster a spirit of continuous improvement. And how do we do that? And how do we keep the teams engaged now that the workshops are done? And as I think I've been in front of you guys before and talked about lean management, and lean management is really the way to do that, to engage the frontline staff with visibility boards, with metrics, with improvement, opportunity for them to participate in improvement. So we're developing a standard to take the current clinical huddle that the nursing staff is already doing very successfully and to incorporate lean management and different this methodology for promoting improvement work. And so we're really excited about that. We actually got our standard work done for the huddle, and today the team was able to train 5 nurses on how to run this improvement huddle just by being on the unit, grabbing people who were working and saying, here, let's show you how to do this. Let me do it for you. Why don't you do it? And so that was really fun. A lot of good support for that by the nurses. So really excited to see going forward how that looks. Okay, so this is my last slide. So I put this slide up because I wanted to show our teams. So we did 5 workshops plus a value stream map. This is all the people that participated in our Kaizen work. This is a huge number of people. You can see it's more than 80 people, including 13 physicians, 40 nurses, and so and 30 staff. And so I think this slide illustrates 2 things. So the first thing it illustrates is the incredible commitment of the organization to improvement work. This is 80 plus people who are pulled offline for 5 days, so they're taken away from their regular work to do improvement work, to just sit together, go to the unit, say what needs to be done, what problems are there, let's solve them. So I just really want to call out, the board of directors, Ms. Farber, our administrators, for giving us the opportunity to take advantage of this incredible wealth of people to do improvement work. And I think it really speaks to the commitment of the organization to quality this is what we're getting to. And then the other thing I think this illustrates is now we have, again, we have 80 people who are trained problem solvers. They understand Lean, they've been given education on Lean, and not only that, but they got to practice it. They got to spend a week learning how to solve problems and being problem solvers. And this group of people they're now going to be our champions, they're going to be our teachers, they're going to be promoting improvement in the organization. And this is just one of the value streams. Through the last couple of years, we've been doing these presentations on all the different value streams we've been doing. So this is just one snapshot of one set of teams. But I really think it just shows the power of Lean in this organization, how many people we're training and how many people really are invested in process improvement and quality. And so, again, really a special thank you to the board of directors, our CEO, our administrative staff for really supporting that. And then absolutely, we could not have done any of this work on the Birthing Center without the leadership of Dorothy, Carmen, and Tigist, really driving that work forward, and our staff, just really putting in their time, energy, and goodwill to helping move it forward. So, thank you.
Thank you. Thank you very much. It's always encouraging to hear these Lean reports and see all the progress that's being made. Thanks to both of you.
I'd like to say thank you to Dr. Kirkjohn. She's been a driving force to have such a strong physician champion is of immeasurable help. And Dorothy has been a strong leader in this as well. One of the benefits of Lean, beyond what's going on now in maternal and child health, is that as we approach our move, Lean has given the organization a common language among all departments for discussing problem solving. And inevitably there are problems in moving into a whole new building. And Lean has made us stronger, more capable, better problem solvers. And I think it will pay huge dividends as we move into the Morris Hyman Pavilion.
Thanks again to that group. Very, very impressive. Yeah. We'll now have our construction report from Robert Alfieri. Welcome, Robert.
So I'll give you an update on the construction of the Morris Hyman Critical Care Pavilion. This is our schedule. It shows that we're in the midst of stock and staff and doing some underground work and utilities. We're getting pretty close. Getting there. So here's the first slide. This is the reception area of the emergency room. This is a nurse station on the first floor, one of 5 nursing stations that were constructed in the ED itself. This is the atrium on the first floor. You can see the furniture is being installed. There's the reception desk and the atrium. Medical office, medical director's office in the ED, being outfitted with furniture. This is a nursing station on the critical care side of the second floor ICU, CCU. 5 nursing stations in all. One of the rooms in the ICU, CCU. This points out also the each room has a couch, sleeper. Also, you can see that the staff is also starting to stock and staff and also starting to do their orientation and training. This is another room, bariatric room on the 3rd floor. One of the features of this room, you could see the lift station for safe transport. This is a nurse's station on the 3rd floor. Again, 5 individual nursing stations on the floor. This shows the connection, or the connecting tunnel corridor from the existing facility into the new Morris Hyman Critical Care Pavilion. They're doing some electrical distribution there. This shows the inside of the passageway. There'll be an enclosed passageway for transport of facilities, patients from the old facility, the existing facility, I should say, to the new facility. This shows also the public entrance, the other entrance into the facility. This is connecting, which will cross eventually a plaza. That's an awning canopy that connects the existing facility into the new. This is the back of the facility. This is where the construction used to have all its layout. Now they're starting to fill that out. They're starting to plant some grass in the area. And let me point out that this is not a lawn. At the assistance of our Green Committee and Paul Kelly and his staff, this is feathergrass. It's a drought-tolerant grass that also helps it with water retention and also filtration into our aquifer. And that's the site view from the garage. You can see that all the paving is completed, and they're working on the site work now as well. And there's our schedule, on schedule, getting very, very close to opening up. Any questions?
Excited about that. It's coming right along.
Yeah,
We're approaching almost just 1 month away.
that's right. September 13th is going to be the ribbon cutting ceremony.
Yeah. So we're getting really close. Thanks for your work.
Thank you.
Worth mentioning, on time, on budget.
Yes. Yes. It's a wonderful, wonderful thing. Okay, now we'll have our quality report from Mary Boron.
Evening, thank you. Before I get into my quality dashboard report, I also wanted to share a little update that about a database that we participate in here called the National Surgical Quality Improvement Project. And it's a national database that Washington Hospital has participated in for about 3 to 4 years now. And it's a database where we submit many surgical procedures and we get data back on our outcomes with these procedures, complications, morbidity, mortality. So basically, if a patient leaves the hospital as expected or has complications while they're here, all of these different elements of surgical procedures go into this database. And we, every year, send a representative from the quality department to their national conference, which we sent them to this year. It was in Florida. And she just returned, Dorothy Harden, and she gave me some feedback about what a great experience she had there this year. One of which was they spend a lot of time educating them on how to sort of run your reports, utilize your data in a practical format, and sort of take all this data and use it to make action and improvements in your organization. So in her particular group, she received quite a bit of great feedback about our organization and some of the outcomes that we have been given exemplary status on. And considering that it's a national database and there are many hospitals, because it's a requirement by CMS to participate in this database, it's a pretty significant achievement to note that, you know, she was sort of being consulted on exemplary status. And it's not just with our joint procedure program, which of course is one of them that is being considered remarkable in this database, but it's even things like, you know, how well you handle appendectomies, how well you handle emergency procedures. If you take a high-risk patient into the OR and you're expecting a certain level of risk-adjusted complications to happen with those patients, we received exemplary status on those outcomes. So it's exciting, and I wanted to share that with you. I will be bringing forward more information on this specific report and summary that they gave us, because we'd like to give you an annual update on it. But that's not due for a couple months, so I wanted to share that with you now. And also, we are considering, you know, submitting sort of a poster board presentation that we discussed in quality a little bit today, because that was also one of the recommendations. We'd like to hear from you, bring a poster board. So we explained you're opening up a new building this year, and so next year that's something we'll be looking into. So from a quality standpoint, that's good news for us and the organization and patients coming here to have surgery, doing well in those areas. But moving into our core measure compliance, when patients come into the hospital, and as I've said before, they're more sedentary, they're laying in bed more, are definitely at higher risk for developing blood clots, otherwise known as venous thromboembolisms. And we look at these data on what we're doing to prevent those. And again, we have had great success with patients inside ICU and outside ICU for preventing these clots. We have been 95% compliant with our bundle in the med-surg setting and 99% compliant overall in critical care. Stroke, continue to do very well on how we manage our stroke patients from a compliance bundle standpoint. We have made sure that for 99% of the patients that were discharged with a stroke received all of their medications and education on how to manage their medications that will stop them from developing clots and having further risk for stroke. All these patients receive stroke education, 100%, as a matter of fact. National state average for that's about 95%, so we're above the benchmark. Also with making sure that all these patients are assessed for and receive the proper rehab while they're here. So great core measure compliance with stroke. Readmissions is another aspect that CMS asks us to look very closely at, especially patients who have pneumonia and are readmitted to the hospital within 30 days. We have been below the benchmark for that. We were at 12.9% of patients. And CMS sees typically about 16% of these patients returned within 30 days. So for us, it was 11 patients out of 85 that came back. Pneumonia is, we've been under the benchmark for quite a while now. Patients who have a heart attack, otherwise known as an AMI, and then a return back to the hospital within 30 days. It's continued to be a little bit of a challenge for us. And of course, this is all-cause readmission. So not necessarily related to coming back with a cardiac condition, but just for any reason, they come back into the hospital within 30 days. A little bit of a decline. We did have 3 patients out of the 17 that had this diagnosis come back within 30 days. We'll be looking more into that moving forward in our readmissions committee. But really what we're focusing on is just sort of drilling down on specific disease states, and one of which what we started with is heart failure. And we really started looking at the interventions that we're doing with these patients, drilling deep in about October of last year. And you can see that we've been remaining under the benchmark for what now is the 4th quarter. We did have 11 patients return with heart failure out of 68 patients admitted over the quarter. This is putting us below the CMS benchmark, and we've been able to, again, manage that for about the last 4 quarters. I think there's a lot of work going on with this in the readmissions committee. I co-chair that with Dr. Halimi. He's working with the medical staff, and we work with a multidisc team on the committee that is from every background, from nutrition, from OT, PT, nursing, case management. So I think we're, being able to say that we've been able to sustain some of the interventions we're doing with that group. Moving into our nursing sensitive indicator, what we're focusing on is making sure that we can do everything that possible to make sure the patients prevent falls while the patients are here. We have been just dead on the benchmark here for what we look at compared to other areas in the hospital, other areas in the nation by using our CalNOC benchmark. This is actually only one fall. It's an abrasion to the elbow, but again, it's an injury counted when we have an unplanned descent to the floor. Still doing well with falls. Moving into our Joint Commission National Patient Safety Goals, of course, one of the primary things they look at is how well are we communicating in between shifts, because one of the biggest factors and contributing factors to quality events or things falling out with patient care relate to communication. It's the absolute backbone of how you can assure quality, that we're all talking to each other in the same standard format and keeping lines of communication open. And we've been able to look at this through direct observation to make sure that these handoffs are occurring correctly. And for this quarter, we were at 100%. Same thing with patient identification, making sure you have the right patient with the right armband and on the right procedure. All these extra techniques that we've put into place to prevent any patient ID errors have been sustained really well now across the board, with patient ID being 100% this quarter. Same thing with procedure timeout, making sure that prior to any procedure that starts, an invasive procedure with the patient, everybody takes a moment and looks and double checks to make sure, is this the procedure we want to be doing on this patient at this time? And we have 99.7% compliance for this. So again, right above the Joint Commission benchmark for that. Moving into our infection prevention indicators, with our central line associated bloodstream infections, we have noticed an increase, obviously, here in the last quarter. We went above the benchmark. We have a 2.5 standard infection ratio. The CDC would expect us to be more along, as you can see, as along the lines of 1. This is a total of 5 central line bloodstream infections. We did a root cause analysis, looked at each one of these cases. We take each one of them very seriously. And these are patients that were had many comorbidities, chronically ill. 2 of them were in the ICU for quite a bit of time. One, in fact, was unstable enough, had a code where they had, went into having cardiac problems, and really we had to place the line in the femoral area, which is, of course, higher risk for getting infected. You can move these lines out quickly. The standard is to move them out and replace them with a line that's up near the subclavian. We do that within 24 hours. But unfortunately, because that area is high risk for developing infection, some of these patients got a central line infection. Patients on chemo, a couple of dialysis patients, things like that. However, in spite of them being high risk, they're patients that we need to look seriously into. What can we do to prevent this? What are we doing as a bundle approach to make sure that we're looking at these lines, making sure, does the patient really need this line? Medical necessity is a big thing with central lines. The patient doesn't get a central line infection if the line's not in there. Of course, if they need the line, they need to have it. But we assess every day, every line for all patients to make sure that can we get this line out to reduce the risk of them developing central line bloodstream infection. So we're looking more into that also. One of these in particular is a patient who arrived with an infection and a type of resistant bacteria, MRSA, that they had actually when they arrived to the hospital. However, they had a long length of stay, and by the 14th day, they were still testing positive for MRSA. The interesting thing about the CDC definitions on this is, even if you have proof that the patient had MRSA while they arrived in their blood, if it has not gone away in those 14 days and you retest, which would be normal to see if the infection is still in the blood, but if you retest and they still are positive for MRSA, they are going to count that as a central line bloodstream infection. What is confusing about this? Yep, that's it. So we had to count that as a central line bloodstream infection. Moving into this next slide, the CDC also looks at just an overall what they call a lab ID. Any patient that was in the hospital who tested positive for MRSA ends up on this slide. As you can see, we have 0. Even though in quarter 6/18, we have a central line bloodstream infection where MRSA was positive. This confused us when we got back the report as that it counts as a 0 MRSA for hospital-associated bloodstream infection. And we worked with the CDC, wrote some conversations with them back and forth, and they said, this is lab ID. We have a different definition for how we do this. This is a different standard for how we measure hospital-associated MRSA than on your CLABSI. So therefore, it's 0 hospital-associated for when it's just the blood, but if you have a central line in, we count it as a CLABSI. So very confusing, 2 different standards, but I'm not complaining about it being at 0, but it's very hard to understand considering that they're counting it as on another CLABSI. So just a little explanation with why that is 0. All this data is public and will be continued to make public on their website. Vancomycin-resistant enterococci infections, another infection that's very difficult to treat with antibiotics. 0 of these in the blood last quarter, which is a good sign for us. We've continued that for a while. Moving into our C. difficile, I've been, obviously you've heard a lot from us in the past about what we're doing to try and bring this number down and help patients to assure that they do not acquire C. diff here. And you can see we've had a great deal of success in heading downward. And now for this quarter, we were actually under the national benchmark. So meaning that we are actually having less C. diff now than other hospitals that are of our size and of our type. A great success to really the entire team of the hospital. I mean, this is everybody from how EVS cleans the room to the protocols and strict protocols and monitoring they've put in place. What we've been able to do with antimicrobial stewardship, which I know you heard Dr. Martin talk about here last month, to basically how we prescribe our antibiotics and taking that very seriously. Infection control, rounding, making sure that people are wearing the protective equipment they need to be. Education to the family has also been a big focus. So I think with that combined approach, we have been able to be going into downward trend. Also, I was just looking at the data for July and thinking, are we sustaining this? And through July, we also had 0 hospital-associated C. diff infections. So fair to say we're sustaining it now, and we want to keep all those efforts in place. Surgical site infections related to colon procedures, we did not have any this quarter. That is required by CMS, and we continue to report that to them. Abdominal hysterectomy, same thing. We did not have any surgical site infections for these patients in the last quarter. One of the areas that we're moving into and really recognizing we need to take a new focus on is hand hygiene. You can see that we're in the second quarter of below the benchmark of the Joint Commission benchmark of 90%. For this quarter, we're at 77.1% hand hygiene compliance. A couple of things have happened here. We have really increased our observations, and we're doing them on the weekends. We're doing them on all shifts. We've added a per diem in infection control. So now you're looking at about 500 observations per month. So overall in this quarter, you're looking at 1,600 observations that were done from the staff. So obviously the sample size is much bigger than it was in the prior months. However, it's 77.1. So recognizing we need to take action. We have been working on quite a few things in place that we're doing with the medical staff and with our employees. And I wanted to take this opportunity to invite Dr. Martin up to let her share some details with you on what she's doing with that. And we also would like to be kicking off our hospital-wide campaign here with you tonight. And she's going to discuss a little bit about how we plan on doing that.
So we take hand hygiene very seriously, and obviously very, very important in terms of our patient ethic, patient first ethic, and we want to make sure that we get increased compliance. We have our secret observers who go around from different floors and in different areas, even in dietary, and we have it in ICU and in all the other medical units. We are working very much as a team approach to each unit. What we would like to do is to be more proactive, less punitive, less accusatory, and more of a team embodying everybody moving forward to our patient first ethic. So what we're trying to do is when we're reporting this, and we do that in the clinical evaluation committee, is we report by unit. So we want each unit to be responsible within themselves. So if they see someone in their own unit that's not washing their hands, they want to go up to them and say, could you please wash your hands? This is really important to our patients and our unit and our standing. And I think we're going to get a lot more involvement that way. I think it's less accusatory. I think it's more in terms of our patient first ethic to move forward and do that direction. In the past, we didn't have as good a compliance by finger pointing, and I think this is a new direction. We really want to try this and make it work. So we want to do it by unit, and each unit is going to be recognized. We are trying to figure out something in terms of a trophy or a pizza party or something we can do to reward those units and show them that, you can achieve good hand washing. So I think that's what we'd like to do. And we want to start out by asking each of our staff to do a hand washing pledge. And we start with our number one team to get them on board to doing our hand washing pledge.
This is a formal attestation, and we want the board of directors' support, and all of the employees in the room are going to be asked to sign their attestations tonight. Thank you. So the public knows what the attestation says. I pledge to prevent the spread of healthcare-associated infections by performing hand hygiene according to the Washington Hospital Healthcare System hand hygiene policy. I pledge to perform hand hygiene according to the following guidelines: before and after patient contact, after eating, after using the restroom, after contact with body fluids, non-intact skin, wounds, and removing gloves. I pledge to become a patient advocate and perform hand hygiene without exception or excuse. I have read and understand the above pledge.
Our next steps after this will be to take this on. We're also having executive staff, as you can see, are participating in signing it and moving this into the employees and having them sign it, and the medical staff will be working together just to make sure that there's a unified approach and a marking point where everybody has made the commitment for us. Anything else? Okay. Any questions? Yes.
Who should be collecting the attestations?
Sure. Okay.
Who should collect them?
Oh, I'll collect them and then we can scan them through and keep track of them.
Okay.
Yeah, we'll do that. Thank you. We appreciate your support with this.
Thank you, Mary. Appreciate all you're doing. Very, very impressive.
Thank you.
I was particularly interested in a unplanned descent to the floor.
I know. I've always found that definition so interesting. And they, even if you have a patient who is on what we call a low boy bed, where it's very close to the floor, but they roll out, when you go back and forth on the definition, they say, nope, it was unplanned for them even to roll out and go, this much of a distance, it's a fall.
Wow.
Unplanned descent to the ground. Yeah, it's always been an unusual definition, but.
I'd just like to make a comment. I want to commend the whole hospital community on the beautiful trend that I've seen in C. diff.
Yeah, it's huge.
I mean, this is something that we've been watching for many, many years, struggling to find what the secret sauce is to get down to the numbers where we have. And it is just beautiful to see that we're down better than benchmark.
I agree, yeah. I have to thank, Dr. Martin and the executive team and everybody and the medical staff. And like I said, even right down to the person who runs the lab test is even calling us now saying, I don't know if this is particularly the right type of stool we should be testing. I mean, we get those calls even now every day.
Right.
We get, like I said, EVS reporting out to us, the stricter cleaning techniques they put in place. It is absolutely a hospital-wide effort.
It's a very complex problem with a lot of different moving pieces, and it's so good to see those moving pieces start to come together to help our patients.
Yeah, I agree. Thank you. It's been great.
It's taken quite a while, but it's obviously all of these things are beginning to really take effect.
So we're thinking, yeah.
I was tempted to applaud when you gave that report.
Yeah, we were, every time we run the report, even like I said before I came here today, I said, please no for July 0. So,
Great.
It's been great.
Thanks again.
Thank you.
We should acknowledge Dr. Martin's leadership and
Yes. I think
I think so.
determination.
Absolutely. Thank you, Dr. Martin.
Secret sauce.
Yes. I think you are the secret sauce, yeah. I think that's absolutely true.
Good.
Thank you.
Move on to our finance report. Invite Chris Henry, our Senior Associate Administrator, to give us the financial report.
Okay, thank you. Tonight we will be looking at Washington Hospital's operating and financial results for June 2018, the last month of our fiscal year 18. So we'll jump right into our operating indicators. Average daily census for the month, as we've seen, a good part of the year was lower than budget at 158. We had 984 admissions. That was 5 above the budget of 979. Our patient days were 335 below budget at 4,740. Outpatient observation equivalent days for the month came in 3 above budget at 184. And our average length of stay for June came in pretty much below budget at 4.51, really hovering around where we've seen it for most of the year. Looking at utilization, case mix index for June was a little higher than budget at 1.551. We had 122 deliveries. We had expected 167. We've been seeing those bouncing around between 113 and 130 for the last 5 or 6 months. So deliveries definitely down. Surgical cases for the month came in not too bad, about 385 for the month. We had budgeted for 398. That includes our joint replacement cases that were 10 below budget at 139. Neurosurgical cases came in at 22. We had expected 28. Cardiac surgical cases were 2 below budget at 12. And the rest of that was rounded out in our general surgery area. Cath lab procedures for the month were 26 above the budget at 368. We had 7,110 outpatient visits this month. We had budgeted for 7,296. And our emergency room visits were 247 below budget at 4,129. Quick look at the cath lab activity. Peripheral vascular procedures really dominated the activity in the month at 45%, followed by cardiac procedures at 36%, non-vascular IR, interventional radiology procedures were 17%, and neurointerventional radiology procedures were 2% of the activity in June. Looking at productivity, productive FTEs for June came in 80.8 below the budget at 1,212.2. We had 204 non-productive FTEs in the month, giving us total FTEs that were a little over 89 below the budget at 1,416.2. Our FTEs per adjusted occupied bed, which is our productivity measure, came in just a little bit below budget at 6.59, so that's a good indicator that we were staffing appropriately for the activity. Moving into the financials. Total patient revenue, obviously off with our lower activity, about 4.7% off of budget at $168,732,000. Contractuals for the month came in quite a bit lower than expected at 74.76. That number was helped out by a couple of things. We did receive a couple of supplemental payments during the month related to Medi-Cal. One of them was, if you can believe it, the 2014 and 2015 supplemental payments for the expansion Medi-Cal population. That's the population that got benefits as a result of the ACA. They're running a little behind on those payments. We also received an intergovernmental transfer supplemental payment of $1.5 million. And just to remind you, that is money that's been left on the table in Washington by the state of California because they won't commit enough general fund money to draw down all the federal matching dollars. So the district hospitals got together and created a program where we give the money to the state to go get that money for us. So that's been really successful. It's brought in $250 million a year to district hospitals in the state. And we're participating in that. So we ended up the month with net operating revenue actually $385,000 above the budget at $43,486,000. Operating expenses for the month came in a little under $2.9 million below the budget at $38,115,000. The biggest contributor to that, you saw our lower FTEs, and you know, the management flexing down the staff really helps when things are slow. So that contributed about $1.8 million to that variance. We also had some positive variances in the areas of provision for bad debt and charity. With that lower revenue, we have lower bad debt, and it was slightly below budget for the month as a percentage of that revenue at 1.5%. Those were really the main drivers on that number. So we ended up June with operating income actually a little over $3 million, almost $3.1 million above the budget at $5,371,000. Non-operating income for the month came in, this is again from the Governmental Accounting Standards Board viewpoint, at a little bit, about $245,000 below the budget at $1,515,000. That included an unrealized loss on our investments of $160,000, so not a lot of movement there given the size of the portfolio. So we ended up June with a total bottom line about $2.8 million, almost $2.9 million above the budget at $6,886,000. If you look over at the year-to-date numbers, really given some of the challenges we've had with volumes, with bad debt that was $4.5 million over what we expected as we continue to see those numbers grow. Pretty solid performance with operating income ending up $13,579,000 above the budget at $28,984,000, and a total bottom line little over $10.3 million above the budget at $46,785,000. So pretty strong performance for Washington Hospital in fiscal year 18. Take a quick look at the Financial Accounting Standards Board presentation. This is adjusted for the way the financial markets would tend to look at us. Operating income for the month stays the same at $5,371,000. We pull out that $160,000 unrealized loss on our investments, and we pull out our general obligation bond revenue that's used to support the debt service on our GO bonds. And we end up with non-operating income from a FASB perspective of $319,000 and a total bottom line of just a little bit under $5.7 million for June. So are there any questions on June results?
Other than wonderful.
Yeah.
Nancy, we go with the operations report.
Happy to. We'll start with preliminary gross revenue figures for the first month of our new fiscal year, July. Our gross revenue of $151.9 million was below budget by $5.2 million. That's a 3.3% variance, and below July last year by $2.2 million, or a 1.4 variance. The inpatient gross revenue of $106.8 million was below budget by $9.1 million. We're still experiencing lower than anticipated admissions. Outpatient gross revenue of $45.1 million was above budget by $3.9 million. The major drivers of the revenue variance include inpatient surgical services volume being below budget by 10%. So our revenue there was below budget by $1.1 million. Inpatient days were below budget by 128 days, a 2.9% negative variance. Our room and board revenue came in $922,000 below budget. A shift in the cath lab procedure mix from cardiac procedures to peripheral vascular procedures drove our cath lab revenue down $412,000. The overall lower activity level drove ancillary services revenue below budget by $2.5 million. The key census statistics include an average length of stay of 4.60, and that was very close to the budget of 4.59. Can't get much closer. The average length of stay was slightly longer than in July a year ago. Outpatient observation days were 42 above budget at 174 days. The average daily census of 137.4 was below the budget, which had called for 141.5. In terms of admissions, we were 36 admissions below budget. We had 919 of them. Patient days of 4,258 were below budget by 128 days. That's a 2.9% negative variance. Our surgical trends, cases in July of 330 were below budget by 3 cases, which is good. That's improved over prior months. Inpatient surgeries were 27 below budget at 241. Outpatient surgeries were 24 above budget at 89. Cardiac surgical cases were above budget by 1. General surgical cases were above budget by 1. That seems to be the magic number this month. Joint replacement surgeries were below budget by 1. So, neurosurgical cases were below budget by 4. Cath lab procedures for July of 318 were 21 cases above budget. Inpatient cath lab procedures were below budget by 6. Outpatient cath lab procedures were above budget by 27. Peripheral vascular procedures were above budget by 37. Non-vascular interventional radiology procedures were above budget at 61. Neurointerventional radiology procedures were below budget by 1. And cardiac procedures were below budget by 21. Deliveries for July of 132 were above budget by 7. Non-emergency outpatient visits of 7,223 were above budget by 115. OB visits were above budget by 65. Hyperbaric visits were above budget by 61. Lymphedema clinic visits were above budget by 25. X-ray visits were above budget by 19. Diabetes education visits were above budget by 19. Infusion center visits were above budget by 14. And lab visits were below budget by 93. In our emergency department, we saw 4,058 visits, and we were below budget by 245. Productivity indicators show that our FTEs were above budget by 10.5 at 1,164.3. Non-productive FTEs came in below budget by 8.1. Total FTEs of 1,385.7 were above budget by 2.4. Total productive FTEs per adjusted occupied bed of 5.96 came in very close to the budget of 6.01. Total FTEs per adjusted occupied bed of 7.9 were slightly below budget. You ask why, with volumes down in certain areas, are the FTEs right at budget? We're beginning to experience the ramping up to get ready for a move. And we are going to have FTEs touring and training, just like we have the doctors touring and training for that new building. And you want the absolute best chance of patient safety. And that's why we're going to be doing this. And you'll see some extraordinary expenses associated with this. Other operational statistics include our surgery center completing the month of July with 479 cases. These were 12 cases above budget, or a 2.6% positive variance. Our clinic visits of 3,262 were above budget by 48. a 1.5% positive variance for the month of July. Washington Urgent Care saw 7 cases more than they budgeted. Nakamura Clinic, 4 less than budgeted. The Newark Clinic, 37 more visits than budgeted. Warm Springs Clinic, 7 clinic visits less. The Ohlone Clinic's plus 15. So, our payer mix. The government-sponsored patient revenue made up 73.5% of total gross revenue. We had budgeted 71.3. That's not a good number. I think everybody understands the federal government, whether you're talking about Medi-Cal or Medicare, does not pay for the full cost of care and never has. And that we make up the difference with commercially sponsored patients. HMO revenue was 2.6% of gross revenue. Came in just a little bit below budget of 3%. PPO revenue was 22.4% of gross revenue, which was just slightly below budget of 23.4%, and that's an important number because that's where we make up the difference between what it costs us to provide service to Medicare and Medi-Cal patients and what we're paid. Private pay revenue is 1.5% of gross revenue. We had budgeted 2.3%. For our financial statistics, days cash on hand for July ended at 183 days, down 10 days from June. The days cash on hand are down from June due to a debt services payment on our revenue bonds, and that payment was $11.8 million. The days of gross revenue and accounts receivable were 52. This is still remarkable performance on the part of our financial services crew. And those are enviable days in accounts receivable for any institution, and they've done extremely well. There were $563,172 in charity care applications pending or approved for July, and so you can see that steady ramping up, going back to business as usual before the Affordable Care Act, where we're writing off hundreds of thousands of dollars and soon to be millions.
Thank you, Nancy. We now have several action items to go through this evening. Dr. Eapen will present those. Item A.
Mr. President, in accordance with the district law policies and procedures, I move that the board authorize the chief executive officer to enter into the necessary contract to proceed with the purchase of implementation services for the Cloverleaf interface engine upgrade for a total amount not to exceed $64,880.
I'm sorry. Bernie looked at me and I started talking.
We
I
have
apologize.
a motion and a second. Now, Nancy, if you could explain that a little bit to the
The
public.
Cloverleaf interface engine is used to send information to and from various systems, including many of the Epic applications, blood bank, external reference labs, imaging systems, various biomedical devices. And this is probably one of the more shocking figures about this. Approximately 500,000 interface messages per day are sent over 200 interface pathways. And this is what this Cloverleaf does for us. The last time we had an upgrade was 2012 when we installed Epic. We have 2 installations of Cloverleaf engine to manage message flow in Sacramento and in the Fremont data centers. And this request includes upgrades to both installations.
Good. D, take the roll, please.
Director Stewart,
Aye.
Director Wallace, Director Eapen,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Thank you, Dee. Move on to item B, the FibroScan 502.
Mr. President, in accordance with the district law policies and procedures, I move that the board authorize the chief executive officer to enter into the necessary contract to proceed with the purchase of the FibroScan 502 Touch for a total amount not to exceed $110,107.
Second. We have a motion and a second. Nancy, if you could
I
explain
think
that.
after you hear the explanation, you'll all be seconding this. It is a non-invasive, painless imaging study that evaluates the degree of liver stiffness or scarring that's known as fibrosis. It does this by determining the speed of sound waves through the liver utilizing a sonogram. The ultrasound elastography will separate patients with minimal or no fibrosis from those with advanced fibrosis or cirrhosis. Without this, patients have to undergo something called a liver biopsy, which can have side effects and is an invasive procedure. We have doctors sending patients to other hospitals for this study. It is a test that is covered by Medicare and other insurances, and I look upon this as an act of kindness for our patients and would urge the board to choose a non-invasive test over an invasive test.
Thank you. Dee, if you take the roll.
Director Stewart,
Aye.
Director Wallace, Director Epen,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Thank you, Dee. That motion passes. We'll move to item C, which is the Grifols Blood Bank Analyzer and Abbott Instrument Manager.
Mr. President, in accordance with the district law policies and procedures, I move that the board authorize the chief executive officer to enter into the necessary contract and to proceed with the purchase of the hardware, software, and implementation services for the Grifols Blood Bank Analyzer and Abbott Instrument Manager for a total amount not to exceed $469,747.
Second.
Good. We have a motion and a second. Nancy, if you could explain that.
We're requesting the replacement of our current blood bank analyzer, Ortho ProView. It is currently leased, and our lease expires in November of 2018. Additionally, we're asking to approve the purchase of an Abbott Instrument Manager for the blood bank. The current blood bank analyzer, Ortho ProView, is refurbished and estimated to be over 7 years old. And in the lifetime of that equipment, that's significant. We experienced 7 downtimes in 2017. The instrument is slow, used only to run routine specimens, does not have stat access ability, and therefore all of our stats are now done manually. Manual entry of results is not as reliable as automated resulting directly from this instrument. The Grifols Analyzer offers random access for stat testing, faster turnaround times, and interface capabilities. The Abbott IM is required for the blood bank and the COAG instruments for rule writing, interfacing with Epic, and auto verification. This project, if it is approved by the board, would take approximately 6 months to complete and would be performed using both internal and external labor.
Thank you. Dee, we'll take the roll call.
Director Stewart,
Aye.
Director Wallace, Director Epen,
Aye.
Director Nicholson,
Aye.
Director Danielson.
That motion passes. We'll move on to item D, which is the Backup and Recovery System Replacement.
Mr. President, in accordance with the district law policies and procedures, I move that the board authorize the chief executive officer to enter into the necessary contract and proceed with the purchase of implementation services for backup and recovery system replacement for both the Morris Hyman Pavilion Data Center and the Sacramento Data Center for a total amount not to exceed $811,727.
Second.
Motion and a second. Nancy, if we could have that.
This is for our information services systems. Our current backup and recovery systems were purchased in 2012 with the advent of Epic. And in the life of IT, that was eons ago. These systems have been upgraded, but they are currently out of support and we're unable to expand them to meet the future needs of our organization. The replacement solution is needed to accommodate backup storage for both Morris Hyman Pavilion Data Center and our Sacramento Data Center. And it provides the ability to back up and restore information and devices in both data centers. In addition, the replacement solution improves our backup processes and has the ability to scale to our foreseeable needs and improves the support of some of the newer software releases. That's the other problem, is that software changes. This is something that we have budgeted. It will take 2 months to fully complete. We will accomplish this using internal labor as well as vendor resources.
Thank you. Thank you. Dee, if you take the roll.
Director Stewart?
Aye.
Director Wallace? Director Eapen?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Thank you. That motion passes. We're now at a point in the meeting where we need to adjourn to a closed session. We reconvene this meeting to an open session and announce that no reportable action was taken during the closed session. There being no further action tonight, this meeting is adjourned.